priorities. Our presenter will be Dr. Jasmine Zain from Memorial Sloan Kettering, and she led the T-cell lymphoma program at City of Hope for many years prior to that. And then our panelists will be Dr. Swami Iyer, Alejandro Sica, and Dr. Mohamed Kharfan-Dabaja again. So I think I'll invite all those folks up to the stage, and then we will hear Dr. Zain's presentation.
So good afternoon, everybody, and thank you for being here. It's been a pleasure so far listening to the B-cell discussions. So I have been given the task to talk about unanswered questions and top research priorities in T-cell lymphomas, specifically nodal T-cell lymphomas, and thank God for that because it's, it's a huge field, and to try to come up with some questions. Now, for T-cell lymphoma, and as far as I'm concerned, everything is a question. So we don't really have those kinds of discussions that we just heard, but I'll try to do my best to give you an overview of what we know. These are my disclosures. So the main question, I can't read this. It's too far away. I thought this was going to be up here. Okay. So basically, the main questions we have that we deal with are, what's the upfront what is the best upfront therapy for patients with nodal T-cell lymphomas, and that includes angiomoblastic T-cell lymphoma now within the classification of T follicular helper cell, PTCL-NOS, and anaplastic large cell lymphoma. The second question is, should these patients be offered an autologous stem cell transplant in first remission? What to do in cases of relapsed disease, which is the majority of patients, and then allogeneic transplant, obviously. And then there are, again, as we just heard, lymphomas don't occur, mostly occur in older patients, and some of these therapies are not an option for them, especially the transplant-based therapies. And so what do we do with those patients? And then there's the rare subtypes of T-cell lymphoma where none of this really applies. We don't know what the best options are for treating them because they're excluded from, or there are very few of those patients included in clinical trials of T-cell lymphomas. So what do we know so far? This is the NCCN guideline panel from for upfront therapy. And, there's multiple regimens listed in alphabetical order, but there's a couple of things that I wanted to point out. First of all, there's only one study that's been a randomized study and has the highest level of evidence. And then at the bottom, you see a little box that says, offer autologous transplant in first remission. So, and then this is what NCCN recommends, and I've been on these guidelines, and I can tell you that we discuss these things, and we just kind of, the level of proof is not great, because we are dealing with rare diseases, heterogeneous diseases, multiple subtypes, and then also the fact that, the studies are all very small. So thankfully, we have good collaborations, and so we have been able to make some progress. I've just outlined here the heterogeneity of T-cell lymphomas as of the latest ICC or WHO classification. It's not one disease. It is multiple diseases, and again, we're focusing only on the nodal subtypes today. If you look at the molecular landscape of T-cell lymphomas, this is just PTCL-NOS. You can see there is a huge heterogeneous genetic background for these diseases. Unlike, say, mantle cell lymphoma or even follicular lymphoma, we don't have specific translocations or chromosomal abnormalities, except maybe in the case of ALK-positive ALCL. But if you look at the genetic landscape, there are epigenetic dysfunction, there is dysfunction in the T-cell regulatory pathways, there's dysfunction in cell cycle, and of course the tumor microenvironment, which is a whole other area of research that affects the outcomes of these patients. So again, these are heterogeneous diseases with a very heterogeneous molecular background, which makes it hard for us to try to figure out what to do. This slide, I just wanted to highlight the progress in the field of T-cell lymphomas. And if you can see, the first few sort of bars are all about identifying T-cell lymphomas, classifying them. And then we come to 2009, where we first get the first approval of pralatrexate and romidepsin as T-cell specific treatments approved by the FDA for relapsed disease. Before that, we were just using, and we still continue to use a lot of treatments used in B-cell lymphomas like CHOP and ICE, et cetera. Then we have belinostat. We have a few other agents approved in Japan and China. And brentuximab vedotin then comes along, and they are, that makes a difference because it has a high response rate in anaplastic large cell lymphoma. At the bottom, I want to just show you the progress in the field in terms of outcomes. The first box on the left is from Dr. Armitage, who recognized that T-cell lymphomas did poorly compared to B-cell lymphomas. Then we have 2008, Dr. Vos, who looked at, she published the International T-cell Lymphoma Project, looked at data from multiple centers around the world, and showed us that besides anaplastic large cell lymphoma, the outcomes of other T-cell lymphomas are not that great, and it's not that different from Dr. Armitage's curves. And then when you have more recent data, which looks very similar. So in terms of overall outcomes, we haven't really made that much progress. So in spite of some drugs that have been approved, so there's a lot of work that needs to be done. So this is the first study that I think is of importance in terms of upfront therapy. It is the first randomized clinical trial for patients with with T-cell lymphomas requiring upfront therapy of BV CHIP versus CHOP. We dropped the vincristine because of the neurotoxicity. And this was the first randomized study that actually showed an improvement in progression-free survival and decrease in the risk of death, and it was a positive study. And this led to the approval of brentuximab and CHP for CD30 positive T-cell lymphomas as upfront therapy. And this is really the only sort of strong evidence we have to support this regimen for anaplastic large cell lymphomas and also possibly for CD30 positive T-cell lymphomas. The reason I say that possibly is that when you do the sub-analysis of this study, you find that first of all, this study enrolled 75% of the patients were anaplastic large cell lymphoma. So it was favored in terms of a positive outcome for BV-based therapy. We already knew that BV in the relapse setting of anaplastic large cell lymphoma had a very high response rate. So that helped make the study positive. But if you look at other subtypes, PTCL, NOS, not that much different. And in fact, for angioimmunoblastic T-cell lymphoma, it actually favored CHOP. So this sort of makes you think that, can we apply this to everybody? In practice, I do, but again, we know, even though we don't know how much CD30 you really need, we do know that anaplastic large cell lymphoma, where it's more than 90% CD30 expression, patients do better. So we really need to find targets that we can address better to improve these. I mean, that's kind of the proof of principle. When we get to the RO-CHOP versus CHOP study, it's a negative study. So initial data from the phase 2 of our RO-CHOP was positive. It looked like it should be a positive study, but this was all comers treated, again, in the randomized fashion with RO-CHOP versus CHOP, and the outcomes were not different. So this unfortunately led to the disapproval of romidepsin from FDA. But again, if you look at certain subtypes, so T follicular helper cell subtypes that are outlined in the red had better outcomes. And so, again, this study was not selected for a specific subgroup. So in general, if we try to apply these targeted therapies, it doesn't really seem to work. So we need to really pick the right patient to find the right combination. And we're still looking. Now, this is how we approach our relapsed disease patients, or even upfront therapy. We try to treat everything with the same tools we have, and unfortunately, that's why the results are one reason why results are as what they are. So so moving on to the question of transplant now. So we've had a patient, we've given them induction chemotherapy. NCCN recommends we should consider an autologous transplant. And this is kind of like the breakdown of the recommendations. If the patient achieves remission, auto transplant. If they don't achieve remission and they can get second-line therapy. And if they have not had a prior auto, go to an allo. And for relapse disease, it's really just an allo transplant. For other subtypes, gamma deltas and hepatosplenics, we offer allo transplant in first remission. This was an education session at the ASH, and I thought it was very nicely put together. What is the effect of upfront transplant? Are we improving outcomes? So this, if you look at, actually, if we go back to this slide, I did a PubMed search, and there were over 471 articles that matched, had the words transplant, PTCL in them. And in spite of all that, we really don't have good recommendations about how to transplant them, what conditioning regimens to use, and again, there's a lot of disagreement about who should, whether we should even offer the transplant. I think Europeans really don't believe in transplant. So I'm going to go back to this slide. This is, I'm comparing Julie Vose's international T-cell project data on the square, which is on the left, and looking at the study that is one of the larger studies for transplant. It's an older study now, where they used CHOEP or CHOP as an induction regimen, and patients who achieved remission went on to get an autologous transplant. This came, and you can see the outcomes. They did show improvement in survival, progression-free survival, and you can see that the best outcomes were, again, with anaplastic large cell lymphoma, but you also improved outcomes of patients with angioimmunoblastic and PTCL-NOS patients. So again, we don't have randomized trial data to say whether transplant is better or not. We have a lot of prospective and sort of institutional studies, but based on consensus, there are people who believe in transplant and offer it to patients with nodal disease who actually achieve remission versus patients who actually, people who really don't think that makes a big difference, because again, autologous transplant is like myeloma is not curative. We know that, and we talked about that to our patients, so why subject them through that? Having said that, and again, we've been doing this, me and Dr. Iyer, for a long time, and some of our other colleagues, we have found that some patients actually do better. So it's just a matter of finding the right patient. But it can't apply to everybody. If your patient is older or elderly, then it's really difficult with comorbidities. And this is where I wanted to show you this study that just got, that shows that if you go back to Echelon 2, again, the BV CHOP versus CHOP, it wasn't designed to test the transplant question, but there was a sub-analysis, because the question of patients who achieved remission and went to transplant was left to the physician. But what this showed us, that only about 20 to 30% of patients actually went to an autologous transplant, even though they had achieved CR and were transplant eligible. So it's not, and most of them, again, it seems to be more in North America. It's not a common practice in other countries. So only about 30%. So that leaves a big chunk of patients who are not receiving this therapy that may or may not be helpful. Now let's talk a little bit about relapse disease. Outcomes are really poor. We have the British Columbia data showing really poor outcomes of relapse PTCL. If you go back and look at the studies from pralatrexate, romidepsin, and belinostat that were done in patients with relapse disease, again, long-term data, long-term survival is really poor. Brentuximab vedotin seems to have the highest response rates in ALCL and the longest progression-free survival, but overall, we're not doing great with these patients. So what about newer drugs? So these are some of the targets that can be addressed in T-cell lymphomas at the moment. We have several trials ongoing that fall into these different categories. We know there's a lot of epigenetic dysregulation, so there is epigenetic agents, and I'll show you a little bit of data on that. There's targeted therapies, including PI3 kinase and JAK-STAT inhibitors. I think those are the two most exciting drugs at the moment in this field, with lots of clinical trials, nothing approved yet specifically for T-cell lymphomas. And then you have the immunotherapies and the failed CAR-T trials that we've had, the CRISPR, which is still ongoing, but we had great hopes for that, but didn't really pan out. And then certain immunotherapy options. Just briefly showing you some of the data with the PI3 kinase. So I think duvelisib is something that we've all participated in this PRIMO study, and the data is now maturing, and we're hoping that this will eventually at some point get approved for T-cell lymphomas. We certainly use it a lot in our practices. It's in the NCCN guidelines. And here again, you have responses that are closer to 50% in PTCL-NOS, higher in angioimmunoblastic T-cell lymphomas. This is better than made some progress compared to pralatrexate or romidepsin, which was about 29%, 30%. But again, subtypes make a difference, and ALCL didn't do as well with this agent. So again, when you're picking your agent, you've got to think about what subtype the patient has. This is another PI3 kinase inhibitor. I think Dr. Iyer was part of this study, the tenofovir. And then we have a couple of others that target a different isotope of the PI3 kinase inhibitor. And we have response rates that are very similar. The main toxicities are the same toxicities we see with this class of agents in other lymphomas. I know they're not very popular in B-cell lymphomas anymore, but again, the same issues: rashes, diarrhea, pneumonitis, increased liver enzymes. This is a study of, let me see, what is this? Oh, this is the oracle, sorry. Again, I can't see from here. So this is the phase 3 study of epigenetic, of a hypomethylating agent, oral azacitidine. There was some data coming out of patients who were treated with oral azacitidine because they had T follicular helper cell and an MDS kind of clone, and the French put together a few case studies and looked like 5-azacitidine was active in T-cell lymphomas. So this led to this study of oral azacitidine versus investigator's choice, which was either bendamustine, gemcitabine, or romidepsin. And we were hoping that this would actually be a positive study, but it didn't do any better as a single agent than what the standard was. But but if you look at overall survival, it was better in patients who actually received the 5-azacitidine. So this is something that's, again, being studied in combinations. Then you have histone methylation. One of the bigger agents or the big study in T-cell lymphomas is with velamidostat, which is an EZH2 inhibitor. And the data is maturing. It showed good responses, again, close to 50%, very similar to the PI3 kinase story. Less responses seen in ALCL. Toxicity profile was slightly different than the PI3 kinase inhibitors, actually was much better tolerated. I actually at City of Hope still have a patient who's been on it for about 4 years, and I think there's a patient in Memorial as well who continues to be on this agent. It's an oral agent. And so at this point, because this is a Daiichi compound, it's been difficult to work with them to do other studies. I think we're looking at other EZH2 inhibitors and looking at combinations, even in the upfront setting. Then the JAK-STAT pathway is another important pathway. There's dysregulation seen in a lot of different subtypes of T-cell lymphomas, including NK T-cell and the intestinal metals. Here, this is a study came out of Memorial Sloan Kettering of ruxolitinib. And they actually tried to look at some of the biomarkers. They divided the patients into 3 cohorts. The cohort 1 patients actually had a JAK-STAT mutation. Cohort 2 had actually a presence of STAT3 by immunohistochemistry, and cohort 3 was a group that didn't have either one of those. And you can see the response rates here of ruxolitinib as a single agent, which is now being studied in combination with duvelisib at MSK. There's another study, this is called the JACPOT study, another JAK-STAT inhibitor. This was not done in the US, but you can see the response rates here, again, in relapsed refractory PTCL. Just wanted to show you that there's other JAK-STAT inhibitors. We were doing a trial with pasiritinib at City of Hope. So again, another pathway to be explored. This is an interesting slide that I just wanted to show you. This is the PETAL consortium, which is looking at, coming out of Mass General, but they're looking at outcomes of T-cell lymphoma patients. They're collecting data prospectively on patients with T-cell lymphoma for both upfront and relapse setting, and they're just following them through and also collecting molecular data. This is their retrospective part, and they've just published this in January. And what this shows is there's a couple of things. First of all, they tried to show that patients who received what they call single agents in relapse setting, and this includes the romidepsin, pralatrexate, brentuximab vedotin, versus standard chemotherapy, things like ICE in the relapse setting, did better. Because one of the questions that arises is when you're faced with a relapsed patient, should we do a single agent romidepsin? Shouldn't ICE be better? It's more, it's more potent, et cetera. And it's taken some time to educate people that you need to really think about these other agents that are non-traditional or non-B-cell based regimens. And the other thing was the effect of transplant. So if you got a single agent, it's called SA, and you got a transplant, your outcome was better. So this is retrospective data, and we're hoping that it actually pans out prospectively. It's multiple centers in the US, I think also in Canada. So here is my approach to how to make sense of this all. And it's basically looking at the different subtypes. So anaplastic large cell lymphoma, you want to, in the relapse setting, you want to go with brentuximab vedotin and some of the other agents and avoid maybe the JAK-STAT inhibitors and PI3 kinase inhibitors. Pralatrexate seems to be an agent that you can use. For T follicular helper subtypes, you can go with epigenetic agents or any of the targeted agents. Almost everything does better in angiomoblastic T-cell lymphoma compared to PTCL-NOS or ALCL. And then you have others that sort of don't fall in these categories, and you have to think of how, other clinical trials. Everything that we know about all agents in the relapse setting, none of them are curative. And really, we have to think of them as a bridge to transplant, or an allogeneic transplant. And so even with the CAR studies that we did, we actually thought that, we found that we really just needed to eventually transplant those patients. They weren't durable responses. So allogeneic transplant, and this is Dr. Hamdani's work from the registry. There are several studies, institutional studies, et cetera, but this is sort of like a combined registry data that we start to see some flattening of the curves in both progression-free and overall survival after an allogeneic transplant. Obviously, it comes at a risk with toxicities, and the curves are very similar to each other. And one thing that makes a difference is the state of remission at the time of transplant, both in progression-free survival, toxicity, and overall survival, and risk of relapse. So agents that can get you into remission are really needed before you consider an allogeneic transplant. It doesn't work well in the refractory state. And I think that's my last slide. So in conclusion, I want to say that these are heterogeneous diseases. We need to really look at the differences in these diseases and really look at the biologic differences and try to conduct trials that are rationally designed to address those differences and find, I think all 25 of these diseases should be treated differently. And that's where I want to end and take questions. Thank you. You want me to? Okay.
Thank you, Dr. Zain. That was a great overview of a very complicated topic. And I think we have about 20 minutes for our panel discussion. And there's plenty of controversies here to discuss, so I think we'll have more than enough to cover. I wanted to start maybe with just a question. You had a slide earlier that showed if patients did not achieve, it was a little MCR. I presume that means molecular CR, or like you're using MRD, or what does the little M stand for?
No, it's not MRD. We don't have any.
Oh, you have a microphone next to you, I think, yeah.
No, it wasn't MRD.
So what does that little M refer to then?
I think that was a mistake.
Okay.
Metabolic.
Oh,
no,
metabolic,
actually, it's not even
sorry.
that. I think it was a mistake. It was probably just a...
Well, I actually did have a question about that. Are you using any kind of MRD in these T-cell lymphomas, and where would you find that to be potentially? Can we use that to identify people who are heading for trouble and maybe transplant them before they get into trouble, or do some other novel approach?
Sure. That's a billion-dollar question. We don't have anything that's currently sort of proven to be a right technology for the MRD. There's a couple of trials that are ongoing. Well, first of all, how do you define MRD? So one of them is the TCR receptor. You could look at that in that particular individual. It's difficult to do that because every patient is different. You would have to make primers for each specific patient. The Alliance trial, which is ongoing currently, which is a 3-arm study of upfront treatment in CD30 negative T-cell lymphomas. It's CHOP plus DUVI, CHOP plus 5-AZA, and CHOP by itself or CHOEP. They are looking at MRD in those patients. They're working with Stanford, Dr. Alizadeh, he has a technology to look at that. And I think there's this study out of Mass General that's also trying to look at MRD in the stem cell aliquot of before the transplant to see if we can. So we're very early in this field, really, to try to figure that out, because I think that would really make a difference. Because if you could see who had MRD positivity, just like you did in mantle cell or other B-cell lymphomas, I think that would make a big difference, and you would know how to approach those patients. Unfortunately, we're not there yet. We do have some molecular data, like P53 mutations have a poor prognosis, so those patients probably if you have that mutation, even if they achieve a remission, probably should go to an allo transplant rather than an auto transplant. Then in ALCL, we have certain data, ALK-negative ALCL, where the presence of DUSP22 translocation is positive, but if you have a P63 mutation that drives P53, those patients do poorly, and so maybe should not be offered an auto transplant. So we have some data to select out patients of auto versus allo, but not a great, I mean, I couldn't hang my head on anything at the moment.
Dr. Iyer, looks
Yeah, I
like
totally
you have
agree.
something to add.
No, I totally agree with Dr.
Who I
Zain.
didn't properly introduce is Dr. Swami Iyer from MD Anderson, and I also didn't properly introduce Dr. Sica from Montefiore and Albert Einstein. So, sorry.
Thank you. Thank you for the invitation. I think it's great to be here and to sort of brainstorm about these issues. It's especially T-cell lymphoma. I mean, Jasmine and I and Alec, we talk about our patients all the time, 2 times a week. But one of the corollaries, I totally agree with her, is that somebody gets an auto transplant, goes into remission, and then they do a bone marrow, and they send out, and the bone marrow is normal, and the next thing you see is the TCR is positive. That's not disease. So that's often a scenario that comes up. And the problem is the TCR testing that is done is not, it might be sensitive, but it's not specific. And you have clones floating around. If you look at AITL patients, you have clones of T cells that are floating around at all times. So I think we've still not defined. I think you started with the least controversial topic in T-cell lymphoma.
Well, there is potentially more specific MRD test, just like how we use clonoSEQ in B-cell. There's a clonoSEQ T-cell assay that you, in theory, could tease out the specific lymphoma-associated sequence and not be looking at those other clones. Is that any more useful?
The folks from China have started doing it, but I think it's very early.
Very early. We don't have prospective data to really collaborate that.
In the setting of EBV-associated lymphoma, I think that might be a useful marker, particularly NK T-cell lymphomas and certain T-cell lymphomas.
So maybe I'll ask Dr. Sica a question here. Dr. Zain presented some interesting data. I think it was the PETAL study that showed outcomes based on single agents versus conventional chemo and based on whether they got transplant. So in practice, what comes up a lot is you have a very sick patient in the hospital who's relapsed with a PTCL, NOS, let's say, and rapidly progressive disease, highly symptomatic. They need treatment in the hospital like today. Are you not giving conventional chemotherapy to a patient like that, or is that our only option until we can get something else approved outpatient?
Yeah, so thank you for inviting me. Thank you for all of this very informative session. So in general, many of these agents are not available or are very difficult to get. If you have a patient in the hospital with acute relapse, we need to stabilize them. We, unfortunately, the best we have, we still use chemotherapy to stabilize them and then to proceed into a autologous transplant if we can. We, on occasion, have used pralatrexate or duvelisib in some patients. It takes a long time to get approvals, but we eventually have done it. We have had very good responses, but again, those are anecdotal. We do not have enough data to use those agents instead of using conventional. So unfortunately, most of the time we end up using chemotherapy and transplant if we can.
So that type of a patient, you give just a conventional platinum-based second-line chemo in the hospital?
Yes, we use ICE mainly, sometimes use DHAP or GEMOX. If they respond to that and they did not have an autologous transplant, we would then proceed to an autologous transplant.
In the relapse setting, auto or allo?
If they relapse after an auto and we can induce again, we go for an allogeneic transplant.
So let's say a patient like we just talked about is responding to this platinum-based regimen. They get out of the hospital. Do you continue that regimen, or do you try to get them a single agent based on that data? You don't want to take the chance because they're responding, right?
Well,
anybody can respond to that.
Why mess with something that's worse?
Exactly.
Because of that data that you just showed us.
Yeah, I mean, I think most of the time what we find is that that's sort of like a starting point, and they will eventually get resistant to it, right? So the way I look at ICE is you can't give 5 cycles or 8 cycles of ICE, I mean, in 1 or 2, and then if the transplant's not ready, then you have to switch to something else. I don't know what your experience is, yeah.
Yeah, I totally agree with that. One thing about the chemotherapy, if you go back to the Oracle study, what you can learn, I mean, two things you can learn. One is that AZA is a good agent, but the study has to be designed properly. If the PFS was not 12 months, and if it was 5 months, I think it would have been a winner. Second is those patients who received chemotherapy.
It looked like a positive study to me, almost.
Yeah, overall survival, yes, but that is the secondary endpoint, though. The primary endpoint was not met. The second is the chemotherapy. If the patients get chemotherapy, the median PFS was 2 months. Why? Because they didn't go to transplant. So to the point that Alex was making, if somebody didn't get an upfront transplant, I think that may be an opportunity to convert a chemosensitive disease into high-dose therapy. But in lieu of that, I think the only thing you have is clinical studies. And that's where a scenario where you might use a single agent, look at targets like CD30, that's the lowest hanging fruit. But I think if you, in those situations, I think they should be always considered for an allo transplant.
So you have something to say?
I think that I'm going to use again your presentation first, Tim. In large cell lymphoma B cell type, you get 2 shots. I think in this disease you have 1 shot. And I think the big controversy in my clinic is when you get a patient young, let's say 30s, 40s, in CR1, should we go really for more aggressive than just an auto in that case? I mean, those patients are potentially curable with an allotransplant, and it's totally underutilized now. Keep in mind, obviously, the risk of GVHD and all of those to keep in mind. But now with new regimens, we certainly have a better probability of controlling GVHD, of trying to prevent it, and so on. So I think that allotransplant in the younger patient is totally underutilized, and it's a therapy that certainly is effective. I think even auto-transplant in frontline consolidation is not as utilized as it should be. And many of these patients achieve CR, and they are monitored in the community without any type of intervention. The other challenge, as Dr. Jasmine mentioned, is really that these diseases have always been lumped in a group. And you can look at AITL, it's a totally different disease, even though we tend to look at them as mature lymphoma. So I think the only option we have to really advance this disease is to try to dissect it similar to what we did with ATLL. Look at the genomic profile of those patients, look at what can be targeted. They are very prone to immunosuppression, they are very prone to hypomethylating agents, and so on and so forth. So I think that CHOEP and CHOP, and the reality is they are not effective, and we need to move past that. And we seem to be stuck in that at this point.
Yeah, actually, when I was at MCW with Mehdi and Narav Shah, we kind of had a powwow, and we have another partner, Walt Longo, who'd been doing transplant for decades, about what to do with AITL. And our sort of collective experience was that when they relapse, it's very difficult to get them to transplant. And to your point about having 1 shot, we just kind of decided as a group that we were just going to allotransplant all the eligible patients in first remission, because there is a pretty robust graft versus lymphoma effect there. And so, I mean, so far, the ones that we did, it worked out pretty well, but every so often it will, bite you. But are there any other patients for the whole panel that you would strongly consider an allotransplant in first remission?
All the gamma delta T cell lymphomas, the hepatosplenic T cell lymphomas,
Hepatosplenic.
ATLL. I mean, you can barely get them into remission.
Right, those are tough, yeah.
And the only survivors, at least that I have, are the ones who had an allotransplant. And then cutaneous T cell lymphomas is a whole other disease, and eventually the only curative therapy there, quote unquote, is still an allotransplant.
Which entity? Sorry, I didn't hear.
Cutaneous T cell lymphoma.
Oh,
yeah. I didn't go there, but yeah. So some subtypes, the rare subtypes you have. I think for EDL, there's still data that auto transplant is effective. You can get them into remission, but others, it's mostly allo.
I saw some data. Oh, we have a question from the. Yeah,
Sorry,
I should be better about checking the audience. Sorry.
No, I just wanted to go back to what Mohamed said about CHOP and CHOEP not being effective, and as a junior staff, I've always just assumed, I don't know if this is what happened, but I assumed that they took what worked in B-cell lymphomas and said, well, let's just do it for T-cell lymphomas. So one, should we be questioning the backbone that we're using instead of just adding to that backbone? And are there any, future moves to try to change that backbone?
Right, so we've gone back and forth on that in the T-cell community. That's a very valid question, and it's really been discussed a lot, and then eventually we come back to it because we haven't found anything. There was a PEGS regimen, which was etoposide, gemcitabine, and steroid, didn't really show any improvement. I did a study with lenalidomide and romidepsin in older patients, and even though we had good responses, it wasn't robust. I mean, CHOP will still give you a good initial response. It's just not sustained. So that's the problem. So we've talked about it. I think once this data matures, the randomized trials that are doing, maybe we can start thinking about combinations in the upfront setting.
Oh, Maddie has a question.
It's my question is mostly for my learning, right? I'm not a T-cell expert. I struggle with those patients. And I'm just gonna, instead of reading, I'm gonna be lazy. I'm sitting on 3 patients right now. So I'm gonna ask 3 people about my 3 patients. So one question for Dr. Iyer. Once a year, we get a monomorphic epitheliotrophic T-cell lymphoma in MCW, and for whatever reason, it's my luck, it always comes to my clinic. So I have a couple of survivors that I allografted up front, but the 3 other patients I saw, they tend to perf. When they perf, they're sort of like no salvaging those patients. So the question for Swami is like, if you see a metal patient, what's your go-to induction regimen, and do you think about an allograft for those patients? Second question I'm gonna just ask them in a go, right? So second question is for Jasmine. NK T cells, like when they're limited stage, Tim taught me over the years that they do really well with combined modality therapy. We leave them alone. But advanced stage NK T cell lymphoma, like I tend to think about allograft in those patients. If we get them in remission, is that still contemporary practice? And finally, in Wisconsin, for Dr. Sica, we don't see adult T cell leukemia lymphoma patients. And again, my luck, when we see them, it ends up in my clinic. So I tend to think that generally the lymphoma version or the aggressive leukemia version, you allograft them up front. But if you don't do that, I'm sitting on a patient who was seen in community, was given CHOP, of course he relapsed. Then they gave him hyper-CVAD, of course he relapsed. And now he's sitting in my clinic, like what would be your go-to regimen for that patient to get him into remission? And then the patient also has very high HTLV viremia right now. Is that something that gets controlled when you treat those patients, or would you go for an antiviral in that setting? So sorry about like a long-winded 3-part question.
No, a good question.
The EATL case.
The metal.
Metal. Oh,
needle.
yeah.
So yeah, I think the metal and needle split in after 2007. It's called type 2. And the type 1s are treated differently, and there is some sensitivity. They all have CD30 expression. At least you have brentuximab as a choice. Metal is very different. They fall along the gamma delta category. They have JAK-STAT mutations or the pathways. Sometimes they have the SETD2, just like hepatosplenic gamma delta T cell lymphomas. The default, like you said, is CHOP. But I don't think it's a very good regimen. Most patients perf. Historically, what used to happen for metal and needle is that they perfed, went to a surgeon, they debulked, and the chemo was given. So they actually had a better outcome in that situation. But today, most surgeons do not want to touch somebody unless it's a colonic mass and they think it's possibly adenocarcinoma. They go and find that this is metal. But if it's an intestinal mass, unless it's bulky, they don't do that, or if there's a perforation. So outcomes have been poor if they don't go through this pathway because they don't have a bypass. And most patients who get CHOP who don't have a surgical outlet don't do as well. You have occasional patients who do well. So your choice is right now CHOP, but what we have done is to add agents to it. Anecdotes. These anecdotes, no studies, I don't think you can do a study. We had a patient with pegasparaginase and CHOP, another patient with Jakafi and CHOP. And we had another older lady who didn't respond to anything. We just gave budesonide and Jakafi. So, and one of the things that's also clear in metal is it's not just the bulk of the mass, it's also microscopic disease in the intestine that you don't always see. And so what do you do for those patients? And in those situations, you give something that works. But I agree with you that once they do get into remission, you also have to not just do a PET scan, but also do an endoscopy. before and after treatment, and then take them to an allo transplant if possible. But again, the median age is higher, and you have young patients, so there's bimodal. There's younger patients, and also the older patients. Younger patients, I think an allo is the best approach.
I forgot the second case already. Hopefully
So
you
the
remember.
NK cell issue. So yes, limited versus advanced stage disease. So advanced stage disease, I always, try to get them salvage therapy. So it's, it comes with stage 3 or 4. You start with SMILE or one of those regimens that has pegasparagines in it if they can tolerate it. There's now a lot of studies with upfront checkpoint inhibitor combinations as well, and then an allo transplant. I think there is some data for auto transplant in that setting as well, but I always found that allo is, eventually they're going to need that anyway. So.
The last case was the ATLL?
HTLV1.
So for ATLL, we have the Shimoyama classification, the acute and the lymphomatous. For the leukemic ones, we did not have a lot of luck with chemotherapy and many people. So the best answer would be clinical trial, and most of the time we consult, thanks to Dr. Iyer and Dr. Zain and many of other my colleagues. If it is an acute form, I'm using PEG interferon, bictegravir, and venetoclax, and I was able to achieve complete responses. The antiviral issue is controversial. I do use bictegravir because it's a newer generation antiretroviral, and we have experimental data that works. So if they have chemotherapy, I have several cases with acute forms that they responded to interferon, bictegravir, and venetoclax. And then, of course, they need to have immediately an allogeneic transplant. The lymphomatous forms, typically we treat them up front with EPOC. In our future trial, we're also adding interferon and bictegravir to stimulate the immune response. But what I do many times is radiation therapy works really well as part of the bulking and also as part of conditioning. And the transplant or cellular therapy, whatever we use, tends to work much better in those circumstances.
I would say that the other controversy there for the allotransplant is really what's the best regimen for them. No randomized data, obviously, but I think the data from Japan have shown that, I think it's a joint Japanese-Korean study that showed that melphalan-based regimens do better than busulfan-based regimens. Again, not prospective, but certain to keep. And the important factor to keep in mind is that the survival in CR1 is probably around 35–40%, but in CR2, if you don't do it, it's less than 5% or 10%. So even in CR2, you may get a little bit impressed by that CR2, but the long-term outcomes are not good. So the best is to transplant those patients in CR1 with hopefully a melphalan-based conditioning regimen.
So,
for your ATLL patient, maybe you should consider the valometastat study or the CTX131 with Alex.
I was going to ask the group, nowadays when people get newly diagnosed with a heme malignancy, they get this, NGS panels sent off, and is there, and it may be useful in practice or not, but do you routinely send off an NGS panel at diagnosis or on relapse, and how specifically does that information help you in treatment selection?
So we do. I see the son of Dr. Logavi here. So most of the time we get cases in the sinus, and you don't know whether it's a T cell or NK T cell.
Or
sometimes,
just for any T cell lymphoma, I mean.
True.
Yeah.
So there are specific case scenarios. AITL, I think to differentiate between the subtype, I think it's helpful. There are the PTCL, the T follicular helper phenotype that may look very insipid and may end up being called as a PTCL NOS outside, and then you do the NGS, it actually has an epigenetic mutation, so you'd rather put them towards demethylating agent or histone deacetylase inhibitor. So in general, I think we do it because we collect data, but I think the utility is probably not as much as you see in other lymphomas.
Are there specific mutations that would change your approach either?
I just changed institutions, and there's no standard, so MSK has its own impact. It's a panel. So I think one of the things I look for it more in the relapse setting to see if there's a JAK-STAT pathways that are mutated, or if there's an IDH2 mutation where we know that the 5-ASA may actually work a little bit better. I mean, these are soft soft guidances, if you want to call them, because we don't have prospective data to support these kinds of interventions. But it does help in the case of a relapse patient and try to figure out which agent to pick. I wish we would have more standardized ways to look for these mutations, which we don't at the moment.
Yeah, we do. We use neogenomics, but I agree with Dr. Jain and Dr. Iyer. There are no clear guidelines, but we still use it, especially in the relapse setting, because when patients get chemotherapy first, they develop new mutations that we can target in the future, and also we use it as a form of MRD as well.
Okay, well, I think we're supposed to be wrapping up right about now, so I'll thank our entire panel for what I thought was a great discussion, and thanks for the audience participation as well. And with that, we'll move on to the CLL section.